نقدر نستخدم الكالسيوم كربونات very easily. طبعا اشكرك ان انت برضو عايز تعمل individualization, but this requires frequent monitoring and it's very important. Thank you very much.
Thank you.
Thank you. هو ليا سؤال يا دكتور كريم. طب اتفضل يا باشا.
Thank you very much. The bone hunger and the need of the calcium may be extended up to 3 or 4 or 5 months. So I'm confronted with 2 patients by this way. We can ask companies formulating the solutions to give some bags or canisters of high calcium in dialysate. This is very important because nowadays parathyroidectomy is widely spreading, and we need this point to be added to the indication. Thank you.
The 2 millimole is available.
Yes, I know.
The 2 millimole is available.
Yeah, we can ask for more concentration.
Yes.
Thank you.
Thank you, Dr. Karim. Any other question? Thank you, Dr. Karim. We are moving to the next speaker, Dr. Marwa Ahmed. She's going to speak about serum activin and follistatin in post-renal transplant patient.
Great thanks for the chairperson and for President Tariq Baz.
عايز ابارك بس لمروه لانها ويننج الابستراكت بتاعها ويننج مش كده يا مروه؟
ان شاء الله.
مبروك.
بسم الله الرحمن الرحيم. Study of serum activin A and follistatin in post-renal transplant patients, correlation with renal hemodynamics, graft function and survival, under supervision of Professor Dr. Hayam Al-Aggan and Professor Dr. Osama Shhata. Renal transplantation has become an acceptable mode of therapy for patients with end-stage renal failure with better quality of life. In spite of increasing success of renal transplantation, rejection of the transplanted kidney by the recipient still remains the major problem to be overcome. Chronic allograft nephropathy is usually clinically suggested by the gradual deterioration of the graft function, rising serum creatinine, increasing proteinuria, and worsening hypertension. CAN could be due to either allograft-dependent chronic rejection or allograft-independent, including hypertension, drugs, recurrence of the disease. Activin A shares many biological features with the pro-fibrotic cytokine transforming growth factor beta-1, which is primarily responsible for the accumulation of the extracellular matrix proteins in renal disease. Activin A regulates the morphogenesis of branching organs such as the prostate, lung, and especially the kidney. It increases the expression level of type 1 collagen, suggesting that activin A acts as a potent activator of fibroblast. Follistatin was initially identified as a follicle-stimulating hormone-inhibiting substance found in ovarian follicular fluid. It is a high-affinity activin-binding protein that acts as an activin antagonist. The aim of the present work was to study serum activin A and follistatin levels in post-renal transplant patients and their correlation to renal hemodynamics, graft function, and survival. Our subjects, including 40 subjects, Group 1, 20 patients with renal transplant, and Group 2, 20 healthy subjects. All patients and controls showed negative viral markers for HCV and hepatitis B and cytomegalovirus and HIV. Patients with diabetes mellitus, collagen vascular disease, and liver disorders were excluded. As regarding methodology, clinical evaluation in the form of thorough history taking, complete clinical examination, and laboratory investigation in the form of routine CBC, renal function test, liver function test, and serum sodium, potassium, serum uric acid, fasting and postprandial glucose levels, serum cholesterol and triglyceride, HLA matching, cyclosporin trough level, estimation of the serum activin A and follistatin by ELISA, calculation of the follistatin activin ratio, estimation of the serum CRP and serum and urinary alkaline phosphatase by the spectrophotometry. As regards the radiological investigation, the form of conventional Doppler ultrasound examination of the graft with calculation and measurement of the resistive index and pulsatility index. 10 patients were categorized as chronic allograft nephropathy group 1A. 5 of them had biopsy-proven CAN. 10 patients had a stable renal function, non-CAN group 1B. In the present study, 4 patients suffered from attacks of acute rejection episodes, and 5 patients had active CMV disease accompanied with acute rejection episodes. Most of them showed partial response to treatment and proceed to CAN with deterioration of the renal function. There was statistical significant increase in blood urea, serum creatinine, and significant decrease in the creatinine clearance in kidney transplant patients than in the control group. In patients with CAN, blood urea, serum creatinine were significantly increased, while creatinine clearance were significantly decreased than in kidney transplant patients with stable kidney function and the controls. There was significantly higher serum level of alkaline phosphatase in patients with CAN than the controls. On the other hand, renal transplant patients show significant increase of serum alkaline phosphatase in comparison to the control group, which could be attributed to immunosuppressive therapy, cyclosporine, and retention due to impaired renal function. The study showed a significant decrease in the urinary alkaline phosphatase in patients with CAN than patients with stable renal function, the controls. These results may be attributed to the tubular cell dysfunction. Serum CRP was statistically significantly higher in patients with CAN than patients with stable renal function, the controls. This denotes that there is an ongoing inflammatory process in patients with CAN, and this could be one of the contributing factors for its development, renal fibrosis, and with deterioration of the renal function. The result of the present study demonstrated that both groups of patients showed significant increase in serum activin A than the controls. Also, serum activin A was significantly increased in patients with CAN than in patients with stable kidney function and the control. Serum follistatin showed no significant change in different groups. Although follistatin activin ratio was significantly decreased in both groups of renal transplant patients and the control, the finding of the apparently normal follistatin and high serum activin A levels in patients with renal transplantation suggests that the unbound biologically active activin A is increased in these patients, and there was a dysregulation of the activin-follistatin axis with decrease in the response of the antifibrotic marker follistatin, and hence the perpetuation of the renal fibrosis and dysfunction, especially in patients with CAN. As regard to the renal hemodynamics, so the graph showed significant increase in both RI and PI than the controls. Also, renal transplant patients with CAN showed a significant increase in the resistive index and pulsatility than patients with stable renal function, the control. This increase in the RI and PI leads to increased intravascular resistance and decrease in renal blood flow, which can lead to graft dysfunction. Serum activin A showed a significant negative correlation with the follistatin-activin ratio. Serum activin A showed a statistically significant positive correlation with the serum C-reactive protein, which denotes that chronic inflammation promotes renal fibrosis. And it also shows a significant positive correlation with the serum creatinine, RI and PI, denoting that activin A increases with impairment of renal function and increased vascular resistance. Serum activin A showed a significant negative correlation with the urinary alkaline phosphatase, reflecting tubular dysfunction with disease progression. Serum C-reactive protein had a statistically significant positive correlation with the serum creatinine, RI, and PI. Urinary alkaline phosphatase showed significant negative correlation with the serum creatinine, serum CRP, denoting that urinary alkaline phosphatase decreased with the renal dysfunction, which is associated with impaired secretory capacity of the renal tubules in patients with CAN, with intrarenal hemodynamic changes and decreased renal blood flow. Serum alkaline phosphatase showed significant positive correlation with the serum creatinine. This result correlates between the increase in the enzyme activity and the progressive graft dysfunction. Serum creatinine showed significant positive correlation with the graft hemodynamics. In conclusion, Patients with renal transplantation have significant increase in serum activin A level, indicating existence of enhanced activin A activity that increases with deterioration of the renal function in these patients. So its repeated measurement can be a reliable early indicator in prediction and pick up renal transplant patients before the clinical manifestation of renal dysfunction and can. The normal follistatin level in renal transplant patients, which is the antagonistic of activin A and decrease of follistatin-activin ratio, showed that there is a dysregulation of the activin-follistatin axis with the increase of the unbound biologically active activin A in these patients. The elevation of C-reactive protein in patients with renal transplantation, especially with CAN, is positive correlation with the marker of fibrosis. Activin A denotes that there is increased activity of ongoing inflammation accompanied by the impaired renal function among graft recipients. Rejection episodes and the occurrence of CAN adversely alter graft dynamics with increased vascular resistance evident by increase in the RI and PI. These changes were positively correlated with the renal function and serum activin A. Urinary alkaline phosphatase decreased in patients with CAN, which denotes that there is some degree of tubular dysfunction. This is evidenced by the negative correlation with graft function and activin A, so it can be used as a marker of allograft dysfunction. Our recommendation is monitoring of serum activin A is recommended in the follow-up of renal transplant patients, especially with those with increased susceptibility to injurious effect of rejection. Serum C-reactive protein could be included in the follow-up data after transplantation. Strategies that counteract activin A could be included in the protection plan against allograft rejection. Further extended prospective studies are required to investigate if repeated measurement of activin A follistatin system and CRP with the early intervention can prevent deterioration of the graft function. Also, further studies are needed to investigate the effect of different immunosuppressive drugs on the level of activin A and CRP. The measurement of the urinary alkaline phosphatase and renal hemodynamics as non-invasive methods in a larger group of patients with different post-transplant complications, including rejection, infection, and graft dysfunction, are needed for further evaluation. Thank you.
Thanks, Dr. Marwa, for your presentation. We got some time for questions.
الاكتيفين هو بيزيد ليه في لما بيحصل كان او لما بيحصل كونكرينال ريجكشن؟
As a marker of fibrosis, this is the family of subtype of the family of transforming growth factor beta 1 is a marker of fibrosis with CAN.
هو حضرتك قصدك ان هو
pro-fibrotic marker.
هل هو بقى بيزيد قبل ما بيحصل فيبروزس ولا بيزيد لما يحصل فيبروزس؟
لا before هو predictor.
هو حضرتك اللي بتقوليه ان هو في الاول خالص predictor لان الفوليستاتينز اللي معاه ما زادش.
لا no significant.
الفوليستاتينز ما زادش
هو الفوليستاتين is an antagonistic. this is the research. The follistatin يعني الفوليستاتين is an antagonist of the activin.
but هو مش antagonist هو
anti bounding protein. Yes.
فبيحوله اللي هو
inactive form.
فما بيزيدش. انا مش عارف هو ما زادش يعني ده اللي زاد وده اللي ما
زادش. This is our data.
To Muhammad.
Thank you, Dr. Marwa, for such an illustrative presentation, and congratulations for their work. I have almost the same comment. You presented activin as a predictor for coming chronic allograft nephropathy. But actually, it happens when fibrosis already occurs. So it cannot be a predictor. Maybe it can be used as a measure for the degree of CAN or whatever, but I have that, predictor.
No, predictor, why? Because it is increased in patients. Also, it is significant increase in patients with stable kidney function.
There is, stable kidney function is a very wide term. I mean, how can you say that this kidney function is stable? Is it only by the serum creatinine? You still have the RI, you still have the...
We have no protocol biopsy.
protocol biopsy.
We
at
have no
least.
protocol
Yeah,
biopsy.
I mean, you have, if you can say that there is a cut-off, you can measure this, like, let's say, a serum creatinine below whatever. I can't take it as a predictor. You know, it's not a predictor. It's a measure for the degree of CAN, maybe. But a predictor, it's something that it happens when you still have completely, insignificantly changed kidney function.
In other studies, they study the activin A in renal biopsies. In the protocol biopsies, and they found that activin A increases predict can follow up when they follow up.
So they had high activin, and when they have protocol biopsy, they get it. They had the CAN afterward.
Yes.
Of course, there's many other factors that can contribute to this. I mean, anyways, it's a window. We can look through it, but to put it as a predictor, definitely you still need to have a much higher number of patients and longer duration for the study and protocol biopsy. So we cannot just say that it is a predictor just by itself. So because this message, if it's conducted, so everybody will ask for CAN next tomorrow to see if his kidney graft is stable.
Yes.
This is the first comment. The second one is, in the beginning you said that kidney transplant is an acceptable line of treatment. Actually, it is the acceptable, the most acceptable, the only cure for renal failure. So the terminology should be changed. Thank you.
Okay.
Last question, Dr. Ahmed.
هو it's actually it's comments يعني it's very good work indeed يعني والف مبروك على الفايده. انا عندي سؤال او 3 اسئله او 3 كومنتس. حضرتك اتكلمتي على الالكالاين فوسفاتيز.
5 enzymes. No. كان normal لا كان I didn't mention sorry okay في الميلامينات. Thank you.
Thank you, Dr. Marwa.
Thank you. Now the next speaker, Dr. Safwa Toulan from El Menoufe University, assistant lecturer, talking about the predictors of AKI in ICU.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. This work is under supervision of Dr. Hassan Abdelhadi Ahmed and Dr. Mahmoud Qura and Dr. Yasin Salah. I'd like to thank Dr. Saeed Khamis for his support.